Dr. Aaron Grantham is going to be showing a live case of complex multivessel robotic PCI. It's actually a live inbox, and then we can have question and answers too after this, or maybe comments after this.
This first case is a 74-year-old man referred for second opinion for revascularization. He lives about 100 miles west of Kansas City. His relevant past history includes a stroke, which left him with a Parkinson-like syndrome, an unsteady gait, and he has to use a cane or walker. He does have diabetes mellitus type 2. He had an ischemic workup that included an echocardiogram. The echo showed a normal ejection fraction of 55% with no wall motion abnormalities or valvular heart disease. A stress test was done with nuclear imaging that showed transient ischemic dilatation with stress, ischemia in the LAD and circumflex distribution, and 28% of the LV mass was ischemic. He underwent cardiac catheterization in Scottsdale, and he was found to have a left dominant system with a 90% lesion of his major OM2, and a lot of diffuse disease in the LAD with a couple of focal 80% lesions in the proximal and mid portion. So our plan then is to, after having a long conversation with him in the office about these two options of medical therapy versus PCI, he was strongly in favor of PCI. Our plan is to do robotically assisted PCI of the OM2 branch and of the LAD, and we'll perform imaging as well to determine where our stents go and then optimally how well they're deployed. So circumflex OM branch is our first target. We'll get an areocaudal view of that. AP caudal view of that. All right. Inject. Good. All right. So our plan here is to hook up the robot, and then when we'll show that in detail on video. And then we're going to take a couple Scion blue wires. We're going to put one down the main branch of the AV groove circumflex, and then we'll preload a balloon with a wire that we'll use to get into this large OM branch. At this point in the case, I would be break and scrub and going over to the robot, but in this instance, Spencer Gaskin, one of our fellows, our interventional fellows, who's done about 25 robotic cases, is going to be doing the driving for us. And so we'll leave him there, and I'll stay scrubbed in case we need to do any manual interruption.
All right, coming toward you.
And we'll feature Tina LaPerry, who's going to be doing the robotics for us.
Yes.
With great efficiency.
I always start with the arrow pointed towards the patient. Open it up. Go towards the opposite end and take all the brown stickers off of the plastic shield that sits on the robot. And then open the arrow towards you. Grab the plastic piece and open it up. Put your arms in there so you don't have to worry about sterility. And then your assistant will pull the robot out for you. And your main goal is to get the monitor. White piece goes to the top of the monitor. Pull as much towards the circulator as you can. This plastic piece has preset holes in it. These are not sterile, the wheels, so do not touch them. And then you open this little piece up, go underneath the lock. And then you're pretty much set for the cassette. All right. So, the main target is this communications box. And you want to get underneath the lip here, hold on to it, and just lock it in place. And you have to look, connect track clamp. That's done. We open the drive cover and pull out the key.
Get to the gym.
And our drive is good and straight. I didn't eat my Wheaties this morning. Testing cassette. And we are ready to tilt the robotic drive. And you just do that gently. All right.
Okay, bring it over and I'll hook it up. So you can see the cockpit setup. We've got a multifunctional display screen, our power vision monitor. It's got multiple configurations. This is a configuration I use most of the time. So we've got a good layout of our anatomy. So she's engaged the wire in the drivetrain. So Spencer's going to push down, look down and push disable all. Spencer's one of our interventional fellows. He's done about 25 robotic cases. He's been in the cockpit for about half and at the table side for about half. So he's now going to drive the guide wire to the tip of the guide with turbo. So the guide wire control is the middle control. So you've got fluoro control. Yep, enable all. Good, drive the guide wire. Push turbo. Good. Spencer, you're going to push the rotate on retract button. Okay, rotate on retract is an automated wire function that tells the robot to rotate the wire in a particular arc about 205 degrees every time you pull back. So now all we have to do to wire lesion is push forward, and if you want it to rotate, click back. So go ahead and wire the circumflex, Spencer. You can already see that it's in the wrong orientation to get into the circumflex. Keep going forward, keep going forward. Test. Good. Send it on out. Back up. Okay, good. Tina, load up the second wire for him.
Okay. Can you step on for just a second so I can make sure? I'm trying to know we're close. All right. So our main driving wire, I'm going to put the clamp down. I'm going to put the main drive wire in the drive.
So the OM wire is going to be in the parking port.
Correct.
The circumflex wire is going to be driven, and then we're going to flip those out for ballooning and stenting. There you go. See how it flipped right over for you? Too much of a hook on there for you. That's just... Go ahead. You're good. Go ahead. Send it. You're in. Okay. Keep going. Good. So that's good. Tina, let's load up a 2520 RX balloon. So we'll need you to switch the wire in the parking port to the drive port and the wire in the drive port to the parking port. So Spencer's going to just leave all of the options open for device manipulation. So the device control, the guide wire control, and the guide cath control are on. You can selectively turn each one of those off. As you're learning, that helps you to not grab the wrong one. After 5 to 10 cases, it's just intuitive and you don't really need it. So he's going to drive that in. Go. That's good right there. Let's do our first inflation there, Tina, up to 12.
Okay. Going up.
So it's just a 2520 balloon for pre-dilation. Check.
I'm at 12.
Take it down.
Down 12.
I'm going to have you balloon all the way back to the bifurcation. So Spencer, come back and balloon to the bifurcation. That's good. Let's take that up.
Going up.
Go to 12 again. You have to realize that the robot never lets go of the
12.
balloon catheter, and so it'll store some energy, and the balloon will continue. See how it's come back well past the bifurcation, proximal to the bifurcation, down. Okay,
down
Spencer,
12.
take the balloon back in, and we're going to do a measurement. Tina, will you need a test there? Come back. Now, you want to go past the lesion and then back a couple of clicks. So back it up a couple. Stop there. That's about where we want it. We're going to let it sit for just a minute. Let's get a test now, Tina.
Okay, I'm ready.
That looks well into our distal landing zone. That's perfect. Now Spencer's going to back it up to the bifurcation. And first push reset on device. Okay, so push reset on device, and we'll take that distal dot all the way back to the bifurcation. Okay, stop there. Remember, it's going to come a little bit more now. Click the millimeter by millimeter control and back it up one right there. Okay, so that tells us 27 millimeters. So this is often where guide catheter control gets really handy. This is a bit of an angulated, diffusely diseased segment. Sometimes we need to enhance guide catheter control to get a stent delivered. So we'll see how it goes. Stop there. Okay, advance your guide a little bit and pull back on the stent at the same time. Okay, and that'll seat your guide. Advance and pull back at the same time. Pull back more on your stent. Good, okay, now advance your stent.
और patient आ रहा है ना? एक और.
Good, stop there.
नहीं,
Let's take a
तीन
test, please.
All right.
मैंने दो देखे.
I kind of like that. I would go in one dot. Just click it forward 1 millimeter there.
Huh?
And let's go up.
All right. We're going up.
And this may
I'm at 6,
12.
12.
Give me a little test, please. I
Okay.
think we may be back into the circ, but nope, it looks perfect. 16
Going to 16.
and down.
16.
Okay. We'll let the balloon come down, take the balloon back into the guide, and we'll take a picture. Here's where you may need to pull back on the guide catheter because it's going to get sucked in as your balloon comes out of this. Yep, there you go. So you can actually push forward on the balloon and back on the guide catheter simultaneously to really get some guide catheter movement. Keep going until your guide comes out into the aorta. There's a, good, okay, let's come back on the balloon now. And be ready to go forward on your guide if your guide begins to slip way out as the balloon releases. That's deep seating the guide, but that's okay. It's a pretty normal vessel. Okay, now start sliding the guide forward and pulling the balloon backwards. Keep coming. You're good. Perfect. Balloon out. Awesome. Good. Okay, let's leave the balloon right there. Stop. Leave the balloon right there, and let's take a picture. Oh, that's fine. That was that disease when we started, so that's perfect. You just absolutely nailed the ostium of that OM. Good job, Spencer.
So that was a wonderful demonstration of multi-vessel PCI